Today I'm going to be presenting Dr. Judy Gaither. She's the Assistant Professor of Pediatrics, General Pediatrics, and Public Health. She obtained her doctorate in epidemiology from Yale School of Public Health in 2015. After completing a postdoc fellowship in bioinformatics, she joined the faculty at Yale School of Medicine in the Department of Pediatrics. Her research focuses on the impact of the opioid crisis on vulnerable populations. Her work began more than a decade ago as part of her dissertation research, which she received a National Research Service Award from the NIH to study the association between opioid prescribing practices and all-cause mortality among U.S. veterans. In 2015, she began working on a project that allowed her to bridge her interests in adult medicine with that of pediatrics, which resulted in the first national publication to examine hospitalizations for opioid poisonings in children. She followed this work with the first national study to examine pediatric deaths from opioids. Prior to these publications, most of what was known about opioid-related morbidity and mortality came from the adult overdose literature. Her research has been supported by awards for the National Institute on Drug Abuse, the National Center for Advancing Translational Science, the Patterson Trust, the Hood Foundation, and most recently, the National Institute for Child Health and Human Development. And so with that, I will turn the floor over to Julie. We're so happy to have you. Thank you for joining us.
Yeah, thank you so much. Thank you for having me, and thank you for the lovely introduction. So let me share my slides and get started. Okay, can you see that? Can you see my slides? Yes. Okay, just a second. Okay. All right, so today I'll be talking about the impact of the opioid crisis on infants, children, and adolescents. So to start with, I have no financial relationships to disclose or conflicts of interest to resolve. And my objectives here today are to provide a brief introduction and overview of the pediatric opioid crisis. I'll talk a little bit about the roots and the evolution of the opioid epidemic. I'm sure most of you are familiar with how the crisis started by now. And then I'll go into some specifics, looking first at in utero exposure, maternal opioid use, and neonatal opioid withdrawal syndrome, which is what it is called now. Until very recently, it was neonatal abstinence syndrome. It's a term probably you're most familiar with, or NAS. And then I'll switch gears a little bit and talk about U.S. national trends in pediatric morbidity and mortality from prescription illicit opioids, and then talk some about fentanyl and its impact on children, and then talk about the data on how these fatalities are occurring, looking at the circumstances behind opioid fatalities in children, and then look at summary implications for current research and next steps. So just a brief introduction, an overview on how kids have been affected by opioids. So I want to start with, in August of 2019, I wrote an op-ed for the Hartford Courant. And my goal in doing so was to really increase awareness about how children were being affected by opioids and put out a call to action. In general, there's been a failure of the U.S., on the part of the U.S. and a part of us all, to really protect children and to think about what was happening in terms of the opioid epidemic and the number of kids who are being hospitalized and dying. At the time when I wrote this op-ed, about 9,000 children had died in the span of 20 years. And for every death, there were approximately 4 children who were hospitalized for a non-fatal poisoning. And so the most recent data, which is now through 1999 through 2023, shows that the number of deaths have essentially doubled. There are about 18,000 children who have now died. And then in addition to those kids, we also have around 24,000 children who are born each year with neonatal opioid withdrawal. And so I wanted to show you this graph just because it really highlights how things have changed over the years, and the scope and the impact of the crisis. So these are deaths from prescription opioids, heroin, and fentanyl. Over time in 1999, there were approximately 175. These are the y-axis or crude death counts. By 2023, starting around 2021, 22, and 23, we have more than 1,600 deaths over time. This is an 800% increase over time. Oops. Okay, I'm not sure what happened. I went back. Sorry. Okay, so how did we get here? How did we get to the point where children are dying from drugs like heroin and fentanyl, OxyContin, oxycodone? I'd like to talk a little bit about the roots and the evolution of the opioid epidemic. So it really started in 1986. The World Health Organization introduced its analgesic ladder for managing cancer pain. Soon, physicians were calling for treating non-cancer pain in adults. There was a real paradigm shift, a fundamental effort to increase the care of patients with non-cancer pain. In 1999, the VA introduced its pain as the fifth vital sign campaign, where pain assessment was measured just as you would temperature, pulse, respirations. And then in 2001, the Joint Commission for Hospital Accreditation included pain assessment in its criteria for hospital accreditation. So as a result of these trends between 1994 and 2003, there was a huge increase in prescription medications for pain, increased by approximately 154%. For comparison, non-controlled medications, non-opioid medications only increased by about 57% during this time. So here we see from 1997 to 2006 what happened in terms of the particular opioid prescriptions. We've got oxycodone in red, which was the largest increase. In 1997, approximately 16 grams were prescribed per US population. It was up by 133 or 730% in the span of less than 10 years. And I'm sure most of you know now there are three waves of the opioid crisis. The first started with the rise in prescription opioids in 1999. Around 2010 is when we saw there was a push to start controlling, limiting prescription opioids. And so as a result, patients turned to heroin and illicit opioids. And then the most recent wave, the wave that we're still in, started around 2013 with the rise of synthetic opioids, primarily fentanyl. And so I wanted to talk a little bit about, I think we think about the evolution of the opioid crisis in terms of the waves and the types of drugs that are implicated, but there's also been a shift in terms of who's been affected. So in 2023, there are approximately 105,000 drug overdoses in the US. 3/4 of these are from opioids. And we know that fentanyl is now the primary driver of the crisis. This is for adults, and it's true for children as well, as you'll see in later slides. And this crisis that was once confined to young and middle-aged white males is now affecting individuals across all demographic groups, geographic regions, socioeconomic groups. No demographic has been spared, including women and children. And among children, it affects them at all developmental stages, from inter utero to adolescence. So I'm sorry, I'm going backwards. Okay, so in utero exposure, I'd like to first talk about maternal opioid use and neonatal opioid withdrawal syndrome. So in the past few years, there's been a real rise. There's been almost a five-fold increase in the use of opioids among women of childbearing age, ages 18 to 54. Not only an increase in illicit use of opioids, but also opioid use for chronic pain, and then for the treatment of opioid use disorder through medication-assisted treatments with Suboxone, buprenorphine, methadone. And so from these graphs here, these are older data. This is 2004 to 2014. And you can see the concurrent rise. As opioid use increased among women, the pink line here, we see a subsequent rise in neonatal opioid withdrawal syndrome. And then the graph here on the right shows the millions of dollars. In 2004, the cost of caring for an infant with NOWS was approximately 91 million. It is now approximately 563 million. So when we look, though, I think the current estimate is nationally that there are about 7 children born with NOWS per 100,000 births in the U.S. as a whole, but there's great variability in what states are most affected. You can see Hawaii here has the lowest prevalence, but West Virginia has almost 70 births per 1,000. And then you see the same thing here. This is the graph on the right. These are all substance use, so not just opioids, so neonatal abstinence syndrome. So to talk a little bit about NOWS, it manifests as CNS irritability, autonomic nervous system overreactivity, GI dysregulation. These infants in general are very irritable. They're hard to console and soothe compared with unaffected term infants, healthy newborns. Infants with NOWS are more likely to have seizures, respiratory distress, intolerance to feeding, and they're more likely to die during the birth hospitalization. As a result, the requisite monitoring and management of infants with NOWS has increased exponentially over time. It prolongs the perinatal hospitalization, and the resources need to care for these infants. Nationally, the median length of stay for an infant with NOWS is 12 days compared to 2 days for an unaffected term infant. They have higher rates of NICU admissions, and historically, they have required extensive pharmacologic and non-pharmacologic interventions, specifically morphine, benzodiazepines, to manage the symptoms. But in recent years, there's been a fundamental shift in how infants with NOWS have been cared for, in part because of the burden that's been placed on hospitals. The eat, sleep, console paradigm is probably the most well-known, and it's been adopted really as the standard of care in many institutions. And as opposed to the traditional method of caring for infants, which is with medications through what is referred to as the Finnegan approach, named after the doctor who invented it. The Eat, Sleep, Console paradigm focuses on empowering mothers. Mothers are considered the best medicine. They room in, focus on breastfeeding, swaddling, and these interventions are tried before medications are tried to soothe the infants. So when we look at the effectiveness of the Eat, Sleep, Console paradigm, the NIH has it's a clinical trial underway, advancing clinical trials in NOWS program. And the results of this study came out in 2023. Young is the author. She's from the University of Vermont, I believe. And what they found was that the Eat, Sleep, Console, when compared to the standard of care, the Finnegan approach, decreased the time that for infants to be medically ready for discharge without increasing adverse events. Particularly, they looked at inpatient safety, and then it did a 3-month follow-up and looked at whether or not infants who had received Eat, Sleep, Console, whether there was a difference in unscheduled healthcare visits or non-accidental trauma, so physical abuse or death, and they did not find differences in these areas. But in general, the research that's been done to date looking at NOWS has focused on the inpatient hospitalization or the long-term impact of Eat, Sleep, Console, and NOWS, but there is a real gap in knowledge about what happens to these children and their mothers and the families when after the hospital discharge. We know that mothers with opioid use disorder are at high risk of overdose and relapse during the first postpartum year. And that it's also the time when infants, regardless whether they have NOWS or been exposed to substances, are at highest risk for maltreatment, abuse, and neglect, is also highest during this first year of life. So I currently have a K-23 Career Development Award from the NIH to study the clinical costs and challenges of caring for infants with NOWS post-discharge. And I'd like to talk a little bit about that research. So the first of the studies from this research is looking at hospitalizations among infants with NOWS. This is a nationally representative study using hospital discharge data from the Healthcare Cost and Utilization Project, followed infants over 1 calendar year using ICD-10 codes, looked at medical illnesses common to infants with NOWS, also looked at injuries, and then specifically at maltreatment. My sample consisted of approximately 16 million births. Children born between 2016 and 2019, approximately 100,000 of these infants are infants with NOWS. So what I found in terms of all-cause readmissions for the unadjusted readmission rates, infants with NOWS are more likely to be readmitted to the hospital. About 4.2% are readmitted within 3 months compared to all other newborns, and the readmission rate for those infants is around 2.5%. But after adjusting for sociodemographic and clinical variables, I found that infants with NOWS are more likely, substantially more likely, to be readmitted for failure to thrive, serious injuries, and maltreatment, but confirmed maltreatment for neglect, but not necessarily physical abuse. Those results were not significant, so we did not find a difference in the groups. And I'll talk a little bit about these findings now. So first, I think if you look here, you'll see that these are odds ratios, but they can be interpreted as risk ratios. So there was no significant difference for the most part in terms of medical illnesses. Children with NOWS were slightly less likely to be admitted for sepsis, but where we see and slightly more likely to be admitted for seizures, but we see a big difference, almost twofold risk for failure to thrive. But the real differences came with for injuries. So about a threefold increase for head injuries, including traumatic brain injuries, almost a fourfold increase for skull fractures, and then a threefold increase for anoxic brain injury. And then when we look down here so these are infants who actually received a diagnosis for confirmed maltreatment. The results are for physical abuse were not significant, but for neglect, there was a 14% increase for 14 times more likely to be readmitted for confirmed neglect. So what does this say? What does it indicate about these families? It looks like that it suggests that families are dealing with multiple stressors, trying to care for an infant with NOWS, while at the same time managing a substance use disorder, maternal opioid use disorder. But it also speaks to the complexity on part of the healthcare professionals, the birth hospitals, child protective services, of providing safe discharge planning to these families and then adequately following up with them and supporting them in these months at home after discharge. So I want to talk a little bit about each of these areas and what I found from the qualitative research that I've done with mothers and then with providers. So the interviews with mothers, these are preliminary data so far. We've interviewed about 15 mothers, and mothers express that they worry not only about caring for their infants, but also themselves in terms of regulating their emotions, managing the side effects of opioid use disorder treatment, methadone, falling asleep while trying to take care of their infants. They also have transportation and childcare barriers. And then they find that the discharge planning process is complex and stressful because when DCF is involved, in particular CPS, these families often miss out on some of the safe teaching for like car safety and safe sleep that other families receive. And then I think it's very important to note that many of the mothers report I feel a lot of shame and of being judged by the healthcare providers. And this often results in them not going back for the services that they need. There are quite a few services in Connecticut in particular to help mothers with opioid use disorder, the Child Birth to Three program. Yale has some programs like the Family-Based Recovery Initiative. But if mothers are experiencing shame, they're less likely to return for care. And then when we look at the interviews from the healthcare providers and look at matters from their perspective, we see that there's often poor communication with the parents. The parents often don't know what to expect in terms of the Eat, Sleep, Console, how their children are going to be cared for. They're separated from their children at times. There's poor communication between the pediatric inpatient and the outpatient providers. We have outpatient providers who expressed that they were not aware that the infant had NOWS and that the mother has a maternal opioid use disorder. And there's also a real issue between the pediatric providers, the pediatricians communicating with the mothers, opioid use disorder providers. And then there's discomfort in discussing opioid safety with the parents. Many of the providers are under the misunderstanding that an infant, that it's not the right time to talk to parents about opioid safety, storage, disposal, naloxone, because the infant's not yet at risk and they're not mobile. But I'm sure, as most of you have heard, there have been numerous cases of infants who have been exposed to residue from illicit substances, illicit opioids, coming in contact with fentanyl patches. Um, and so this is a misunderstanding, and I'll talk a little bit more about this later. There was the interviews on the part of the mothers and providers has revealed a distrust of CPS or DCF. There's tension for the providers in serving as the advocate for the parent, but then also having to report the family for substance use disorders. There's a lack of investment in home-based models of care. As one physician described it, it's a black hole. What happens to these children once they're discharged from the hospital? And I think it causes physicians a lot of worry, and there just is not great follow-up. And then, as I mentioned, there's a lack of understanding that children are at risk from opioids at any age. And so I want to talk a little bit more about that, a case study, a death of a 10-month-old. This child was born in August of 2020 in Connecticut. He was diagnosed with NOWS and failure to thrive at birth. Multiple systems were involved: the hospital, the child welfare workers, methadone providers, the legal system. but yet there was a lack of communication between the agencies and the providers, and there were multiple system failures throughout, particularly related to drug testing the mother, substance use treatment for the mother and the father, and then safety planning. So this child did have a safety plan created, and in this context, I'm referring to plans of safe care, which are mandated by the Child Abuse and Prevention Act, CAPTA, which is federal legislation that was begun in the 1970s for requiring that states develop safety plans for infants exposed in utero to substances. But as you can see here, so I have quoted the safety plan for this child. Mother will not be left alone, unsupervised while caring for the newborn. Mother will actively engage in treatment with the methadone provider. Mother will utilize father, family, friends, and other natural supports to supervise her. DCF will do home visits twice per week. Overall, this plan lacks objectivity. There are very few concrete measures outlined. How is the monitoring to take place? What are the treatment goals? When will the providers communicate with each other? How will the testing to make sure the mother's not continuing to use illicit substances? How will that be done? And so I forgot to mention, so the mother, urine drug testing was not done for this child, but the mother had admitted to using fentanyl illicitly prior to the child's birth. So the baby was just discharged home in the mom's care, despite the limitations and the lack of a real concrete plan. And my intent here is not to blame Child Protective Service workers. There were failures on the part of the hospital as well. There's no evidence that any sort of opioid risk assessment and safety was discussed with the family as part of discharge planning in the way of using naloxone, lock boxes, how to dispose of opioids. And so this child died in June of 2023 from a lethal combination of fentanyl, cocaine, and xylazine, which is an emerging drug. He was the 11th child to die at the time from an opioid poisoning in Connecticut since 2020. And so I want to talk a little bit now, so segue into from NOWS to looking at U.S. national trends in pediatric morbidity and mortality from prescription and illicit opioid poisonings. And so I've shown throughout some pictures that are publicly available of children who have actually died, very young children for the most part, from opioid poisonings. So the first study I conducted in this area, I used the kids inpatient database. This is from the Healthcare Cost and Utilization Project. And I used the ICD-9 codes to examine prescription opioids and heroin. At the time, I was not able to look at codes for fentanyl. And I looked at accidental suicide and self-harm. And we looked at children 1 to 19 years of age because at the time we didn't have an understanding that infants who are not yet crawling would be in danger of an opioid poisoning. We've since learned that that is not true. And so I'll go through these results pretty quickly. So there are two age groups that are primarily affected, these light blue bars. So the x-axis is years of the study for the HCUP data released every 3 years. This is incidence per 100,000 children. The two groups most affected are the 1 to 4-year-olds in the light blue bars, and then the older teens, obviously, those who are 15 to 19 years of age. And this graph here looks at heroin and prescription opioids among the 15 to 19-year-olds. And you can see that by far that prescription opioids were the primary source of the poisonings. These data are through 2012, and they've changed substantially since then, and I'll talk more about that in a little bit. And then also among the teenagers, looking at accidents in the light blue bar and suicide, self-inflicted. So the majority of the deaths in older teens at this time were from suicide, but the actual trend in terms of poisonings over time was highest among uh, those four accidents. And so over the course of this study, we found on average that there were among 2,000 hospitalizations per year, but only a small percentage died in the hospital. It was actually only 30 fatalities per year. And it was only later that we discovered actually that these deaths represent just a very small percentage of the deaths that occur each year. And so I'll talk a little bit now about fatal pediatric opioid poisonings. So this was a study using CDC Wonder data, multiple cause of death, death certificate data, and I looked at opioid deaths, pediatric opioid deaths from 99 to 2016. Again, using ICD-10 codes, and this time we were able to look at fentanyl, but you're not able with the fentanyl codes to distinguish whether these are prescription for fentanyl or illicit or legally manufactured forms of the drug. And then we looked at intent, and this time we included codes for homicide and undetermined. And we included all age groups for the pediatric, across the pediatric age spectrum. And so our findings here, these slides, what I want to focus on primarily are these two slides here. So these are the youngest children, and these here on the right are the oldest children. So these are smooth mortality rates over time per 100,000, and this time the axes are flipped, and so we have time on the y-axis and then the rates on the bottom. And for the youngest children, we see when we compare them that there's a steady linear increase over time in deaths from opioids. But the trends for the adolescents are here on the right. And you see that somewhere around 2012, things started to change and there was a decline. And this reflects what we saw with the adult population as well. And then they started to rise again. And that's due to the fentanyl primarily, and I'll show you a little bit more about that in the next few slides. And then looking at manner of death, 81% of these deaths were accidental, only 5% attributed to suicide, and a very small percentage when you look at the entire pediatric age spectrum due to homicide or assault. So these children, it's either a criminal neglect or that the parent actually or caregiver actually intended to harm the child. But when we look among the youngest children, we see that 1 in 4 were due to homicide. And then when we look at the youngest children, so more than a third were due to homicide. And then I want to talk just a little bit about deaths in 15 to 19-year-olds. So while prescription opioids, which are shown here in gray, increased one-fold over time from 1999 to 2016, we see a four-fold increase in heroin over time, which is shown here in the red, but take a look at the fentanyl findings. So fentanyl shown here in gray. There's a 3,000% or 30-fold increase over time in deaths from fentanyl. Very few fentanyl poisonings occurred in the early years of the epidemic in 1999, and most of these deaths have occurred between 2014 and 2016. And then I'll show you a little bit more talking about pediatric deaths specifically from fentanyl. So again, for this study, I used CDC Wonder data and looked at prescription and illicit opioid poisonings in general, just to get a sense of how things had changed over time using recent data. So this is from 1999 through 2021, and focusing specifically on fentanyl. So we see that nearly 14,000 opioid poisonings fatalities during this time. And then there were about 9,000 for non-fentanyl, but fentanyl accounted for over 5,000 poisonings. Again, the majority of those affected, nearly 90%, are the older teens, which is not surprising, but consistent with the prior work and the hospitalization data. We see that about 7% of the younger kids were impacted. But I think it's important to also know that a, a large percentage of these kids had died and there was another substance implicated. Um, Benzodiazepines accounted for 17%, and then to a smaller degree, psychostimulants, cocaine, and alcohol. And then the place of death. I think this is important to look at. About 43% of kids died at home. And I'll talk more about that later because I think it has important implications for what we do going forward and how we intervene to help these families. And then again, nearly 90% of the poisonings and the cause of death, manner of death was unintentional. So I wanted to show you this graph because I think it powerfully illustrates how fentanyl is really driving the trends in pediatric deaths from opioids now. So here we have, these are annual observed death counts on the y-axis and over time from 99 through 2021. The gray line are total opioid deaths. The blue line are for non-fentanyl deaths. And here we see what's happened with fentanyl. So huge increase over time. And then there was a surge starting around 2014, and then an even really a great spike in deaths starting in 2019 and during the years of the pandemic. So this represents during this time frame 2015 to 2021, 3,000% increase. And before I leave this slide, I just want to point out that in 1999, the deaths from fentanyl were so low that they can't actually be reported because they would go against, to do so would go against the CDC's criteria for small death counts and privacy. But there were 175 total opioid deaths in general. But by 2021, there were 1,657 deaths, all but 100 were due to fentanyl. So just again, just to speak a little bit about deaths from annual deaths peaked in 2020 and 21. 2021, which is during COVID. In 2021 alone, there were about 40 infants less than 12 months of age who died from fentanyl nationally, and then there were 93 toddlers and preschoolers who died as well from fentanyl. And so I want to spend just a little bit of time looking at the circumstances behind fatal opioid poisoning. So for this study, I used National Child Fatality Review data, the case reporting system. Most states in the U.S. have a child fatality review team. The criteria for which deaths are investigated vary widely across the U.S. Here in Connecticut, all deaths are investigated. The child fatality review teams look at birth and death certificates, medical and autopsy reports, and legal and CPS records to really be able to look at how did the death come about, and the goal is to prevent future deaths. So for this study, I looked at, this is a convenient sample, so it's not nationally representative because not all deaths are investigated. I looked at about 1,700 deaths among children less than 17 years of age who died between 2004 and 2020. And consistent with what we know from the national data, the hospitalization and mortality data, most of the children affected are of white race. So this is consistent with what we know from the adult population as well. About 16% were Hispanic. The majority are male. And then again, we see that the two groups most affected are older teens, younger children, those younger than 5 years of age, and more than half of those families who lost a child were on public insurance. And when we look at the setting of the incident, so this, it may or may not be the setting of death, but this is the setting where the poisoning occurred. 65% of deaths occurred in the child's own home. Another 23% occurred at the friend of a relative or a friend or a foster parent. And only a very small percentage, 8%, occurred in some other settings, such as the hospital or hotel, motel. And then when we look at the cause and manner of death, we see, consistent with the other research, the majority of the poisonings were for prescription opioids, nearly 90%. Fentanyl, actually, there were more deaths from fentanyl than heroin. And then when we look at intent, so whether these were accidents, suicide, homicide, are unknown. The majority were accidents, but there was about 8% of kids for the entire age group, so infants all the way to older teens, died from homicide. But when you look at the younger age groups, more than a third of children under 5 died from.
Julie, are any of the deaths attributed to negligently exposing the child to drugs classified as homicide?
Yes, so homicide, that it's determined by the medical examiner, and it could be that the parent intentionally gave a child, but there's anecdotal evidence that parents give their child, as they do sometimes with like Benadryl. They're giving their child methadone or an opioid to put them to sleep, but it also captures malicious intent, or these cases where it's criminal neglect and the parents acted in a manner that most parents would not have, that they left opioids out, or they left many cases of the child being exposed to Suboxone, because as you may know, Suboxone is a drug that does not come in childproof packaging. Patients will often tear off a portion of the drug, and then they leave it on the counter and the child gets into it. So did that answer your question, Dr. Crystal?
Yeah, no, actually, that's very interesting. In these databases, would you be able to tell how much was involved with buprenorphine strips, for example?
Was involved with what?
Well, you mentioned the scenario with buprenorphine strips. Is that a scenario that can be identified in your data?
No, I mean, it's unfortunate, but you can't, with these national fatality data, you're unable to get that level of granularity, but you also can't get it with the larger databases either. There have been some studies, chart reviews, that have shown that poisonings for the drugs that are used in methadone for medication-assisted treatment, they contribute substantially to deaths in children. Buprenorphine, methadone. We found in the fatality study that poisonings for methadone increased 1,000-fold over time in the span of about 16 years.
Great, thank you. So you have these being wonder data. You have the basic 4 types of opioids, and that's about it for opioids.
Right, exactly. Right. There's just not, unfortunately, a way to really get at the particulars, or to be able to, as I mentioned, look at the fentanyl. Was this from a patch, or a fentanyl that was prescribed, or an illicit form of the drug? And then just moving on to say a little bit about maltreatment. So as we see, this is a theme that for this study overall, about a third of children had been the prior victim of prior maltreatment. So this is for an incident unrelated to the current one that led to the death of a child. About 13% of the sample overall had been placed outside of the home by Child Protective Services at some point, and this number was about 20% for the youngest kids. And then for families, about 10% of families had an open case with Child Protective Services at the time of the child's death. And then also the looking at substance use. So I was actually surprised to find that looking at children with a history of substance use, 42% of the 10 to 14-year-olds had prior history of substance use. That number was 73% for the older adolescents, the 15 to 17 year olds, and then for caregivers across all age groups, more than a quarter had a primary caregiver with a substance use disorder. And for the youngest children, those younger than 5 years of age, it was almost 50%. Looking at when these children died, I mean, the great thing about these data is there's a lot of missing data, but you do get some indication of what happened when the child died and how families responded. And we know that resuscitation was attempted in 74% of the cases for these deaths, these 1,700, but only about 15% of parents are known to have administered CPR. So the majority of the resuscitation attempts were by EMS. We know that for almost 70% of families, poison control was not called. Because these children, these are the deaths, and we don't have cases of non-fatalities. We don't know about naloxone, but I expect that it was low. My anecdotal evidence suggests that even EMS responders are reluctant to administer naloxone to an infant or a young child. And then very importantly, the child fatality team determined that it was clear in 80% of the cases that the death could have been prevented, and only 5% was it deemed that no, that efforts could not have prevented the death. And so just looking over time at common themes across all age groups, and the roots of the problem, a history of maltreatment and substance use disorder, whether on the part of the child or the caregivers, the root of most fatalities. 1 in 4 children age group, the victim of prior maltreatment. So these are definitely high-risk families. The majority of poisonings occur at home. Parents rarely called 911 or administered CPR, which speaks to educational needs. And as I said, at least 80% of the deaths could have been prevented. And so I want to talk a little bit about all of this. And I know it's been a lot, summary and implications. So in general, we can see that the pediatric opioid crisis is persistent. It's a growing public health problem, but with the rise in fentanyl, it's an epidemic that's worsening. It's changing rapidly. Prescription opioids still account for a lot of the poisonings, but fentanyl is now the primary implicated agent, responsible for about 95% of all pediatric opioid deaths. Most children and adolescents die at home. COVID-19 exacerbated what was already a growing crisis. It'll be interesting to see the more recent data and what's happened with trends in pediatric poisonings after COVID. And then this is a systemic public health problem infecting entire families, but it's not how we've addressed the problem. Most of the efforts to date for the epidemic have focused on adults with interventions that are in isolation of their families, and children have not been considered overall. And so what's needed? We need common sense solutions for prevention. The opioid crisis has been ongoing for now 30 years. And I don't believe that most people in general know about the harms that opioids pose to children. Opioids certainly are not being stored safely in most homes. Disposal is not routine. Most families, it's difficult for me to find out where to dispose of opioids. You can take them back to a police station. Some pharmacies will accept them, but it's certainly not made easier for families. We need a greater emphasis on harm reduction strategies, parental and adolescent treatment for opioid use disorder. We need improved access to naloxone for families, and it should be universal for high-risk families. And then we also need family-centered interventions. We need a real paradigm shift in how we treat opioid use disorder in adults. And in particular, the opioid providers for the adults communicating with the child's pediatrician and working together to make sure that patients are protecting their homes and know of the risks that opioids pose to kids. And so I wanted to speak just a few minutes about a couple of interventions I'm developing in this way to be able to address some of these things. Through my I'm developing my K-23 award, a home-based intervention to support families affected by NOWs. And my goal is to extend the principles of Eat, Sleep, Console. This has really been an important initiative in changing how we're treating children exposed in utero to opioids. And we know that it's effective, and being able to build on that and through the prenatal to post-discharge process, and specifically focusing on maternal infant bonding and attachment. Mothers who are more attached to their infant are less likely to abuse opioids. They're less likely to relapse, research has shown. And so a big part of this will be on an educational component, providers and families, making sure that they understand the risk that opioids pose to kids, and that it's something that kids of all ages are at risk, and then talk about opioid safety, how to use lots of boxes, dispose of opioids, how to respond to an opioid poisoning in a child or an overdose in an adult, and then include looking specifically at safety checklists, which are, I'm envisioning is something different than the plans of safe care, which are mandated, legally mandated, but something that really encompasses what parents know about opioids, what resources they have at hand, are they going home with lock boxes, and they know how to respond to call 911 and how to intervene if something happens. And so specific to this, I also have what I'm calling the Kiddo Initiative, Kids in Danger of Opioids Initiative, that I'm developing at Yale New Haven Hospital. It builds on an initiative that was developed in Colorado called the Maternal Overdose Matter, or the MOMS Initiative. And mothers prenatally with this program are being taught about the risks that opioids pose to them, and then being given naloxone at the prenatal stage. And so I'd like to expand on this initiative and include kids as well. And so the goal is for all mothers who give birth to an infant with NOWs at hospital discharge, that the mother will receive a lockbox and told how to use it for opioid storage. A QR code on the box will link to a video related to opioid safety and awareness and emergency preparedness. And then naloxone will be distributed via mixed events approach. So the mother will go home with the drug, and everyone will receive the message that naloxone is safe for children of any age, even infants, but also understand that I think there's a lot of talk about naloxone and it's seen as a cure-all, I think, for the opioid epidemic. But as you've seen from the research I've shown, children are about 50% of the cases involve another drug, a non-opioid medication, and naloxone will not reverse the effects of these drugs. And so just circling back for my final slide to the op-ed I wrote in 2019, um, and a real call to action. The opioid epidemic has been going on for about 30 years now, and we still, most people I don't think know about the risks that opioids pose to kids. It is a shared responsibility that we're all doing our part. We need broad public health campaigns and messaging to increase awareness for families, but also for healthcare providers. Families and communities need to really recognize the home as ground zero and begin to treat opioids as we would any other substance that can harm a child. Understand the risk, prepare for emergencies, have naloxone readily available. We need consumer product regulations, childproof packaging for all opioids, including those used for medication-assisted treatment. For opioid use disorder, providers who care for adults could help by who prescribe opioids for pain or for opioid use disorder by begin asking and talking to families about whether they have children in the home, consider co-prescribing naloxone along with opioids that they can pick up at the same time. And just in general, we need more family-centered and pediatric-specific care to address this epidemic. And then I wanted just to acknowledge the work of my collaborators at Yale and the support I've received for this work, and a link to the kiddo initiative at Yale if you would like more information. And thank you. Happy to take questions.
Wow, that's fantastic. I really wish we had some more time for questions. We literally have time
Sorry.
for like one or two. There's
Yeah,
so many
sorry, I went a little over.
questions. So who wants to jump in quick while we're still on? This is the moment to overcome any shyness.
We do have a question in the chat that others might want to know as well, is if there's a way to access your great presentation slides for review and relearning.
Sure, I can send them out. Should I send them to you, Hannah?
Yeah, you can go
Okay,
ahead and send
great.
it to me. Yeah, that'd be great. I'm happy to
Okay,
disperse.
thank you.
I have a question, might be more than just 1 minute, but I was wondering if you're doing anything moving into stimulant use disorder and thinking about, I feel like a lot of the intervention aspects and safety of medication storage, or if you've had any thoughts on that.
So specific to stimulants?
Yeah, I guess I was thinking with fentanyl involvement and stimulants, and if you've seen parents or mothers with stimulant use disorder, and any thinking about looking at that area, I guess.
No, I haven't. But that's an interesting topic. Yeah, but I haven't done that work so far.
Thanks.
I'd love to see more empirical information on at least self-reported lockbox use. There was a lot of efforts when they started expanding the methadone take-homes to provide people with lock boxes, but one wonders whether that should be standard of care for any MOED that for people for adults with children in the home. So it's a very ripe area, and we could have such an interesting conversation on the in-home delivery and what a preventive program would look like, and who it takes, what type of personnel it takes to work with parents in the home to actually achieve greater safety. But I don't know, maybe when you've done more on that, we'll have to have you back.
Okay, yeah, that I'm hoping to include an assessment component with the kiddo initiative and the lock boxes. But my understanding, there have been studies reporting on families who are using lock boxes, and I think they estimated it was about a third of the sample. But I think the number is actually much lower, and that most families are not.
Yeah.
Well, I want to thank you, Dr. Gaither, so much again for joining us and sharing your work and your expertise with our NJAX community. And thank you all for tuning in to this month's webinar, and we look forward to seeing you at next month's webinar.
All right. Thank you so much.
Thank you.
Good afternoon,
Take care.
everyone. Bye-bye.
Bye.